Greetings to all of our attendees in the chat, our esteemed panelists, and our audience all over the world, even if you're watching this from a replay. My name is Dr. Nanine Wemer. I'm the Managing Director of the Physicians Association for Nutrition, or PAN International. PAN is a global medical nonprofit organization working to advance nutrition in healthcare for personal and planetary health, ultimately helping to reduce diet-related disease and death. It is a pleasure to welcome you to today's webinar. I will be your moderator for the discussion, which brings together perspectives from cardiology, real-world clinical practice, and broader health systems. Today's session forms part of our 2026 global campaign, Food for the Heart. This campaign is focused on advancing evidence-based nutrition as an essential part of cardiovascular prevention, management, and reversal, and on helping bring that conversation more clearly into everyday healthcare practice. Thank you so much, everybody, for being here and also being as passionate about nutrition and healthcare as we are. We'll also follow up after this webinar with additional resources, including a summary and materials to help you continue engaging with this topic. So we encourage you to follow us at PAN International or your local PAN office on social media to stay connected for upcoming resources. Food for the Heart comes at a very important time when cardiovascular disease remains the leading cause of death and disability globally. And much of that burden is linked to modifiable risk factors, including dietary patterns and other lifestyle drivers. At PAN International, we believe nutrition has an essential role to play in cardiovascular prevention and management, not as a replacement for standard treatment, but as a critical part of comprehensive evidence-based healthcare. Yet in many settings, nutrition is still not consistently integrated into routine practice. Is this what you experience as well? Let us know about your setting in the chat. The evidence is clear that nutrition can support risk reduction, improve heart health, and contribute meaningfully across both prevention and management. So one of the key questions is not whether nutrition matters, but how we make it more practical and better supported in real-world clinical settings. And that's what today's webinar is about, helping to close the gap between what we know and what happens in practice. So over the next hour, we are going to explore how nutrition can be more meaningfully integrated into cardiovascular healthcare, what evidence-based nutrition for heart health looks like in practice, how clinicians can raise these conversations in realistic consultations, and what support, education, and systems change are needed to make this easier across the healthcare team. Here is what you can expect for the session. I will now introduce both of our speakers at the start, and then we'll move into two presentations. You are invited to post your questions in the chat. We will have time for a dedicated Q&A at the end. So please ask us your questions and we will choose some at the end. So I'm going to start now by introducing both of our speakers, starting with Dr. Rajendran. Dr. Rajendran is a professor and senior consultant in cardiology at PSG hospitals in India. He brings many years of experience in preventative cardiology with a strong focus on patient education and prevention in both clinical and community settings. We are especially grateful to have him with us to open today's discussion with an India-based perspective on how nutrition can support heart health in the real-world practice. And after Dr. Rajendran, we will hear from Professor Sumantra Ray. Professor Ray is a UK licensed medical doctor, registered public health nutritionist, and the chief scientist and executive director of the NNED Pro Global Institute for Food, Nutrition and Health in Cambridge. Professor Ray has been a leading voice in advancing nutrition education and strengthening the role of evidence-based nutrition in healthcare. We are delighted to have him with us to help deepen the conversation on why nutrition matters in cardiovascular prevention and care, and what it will take to integrate it more effectively across healthcare systems. Thank you so much to both of you for being here with us today. We'll now move into the presentation component, starting off with Dr. Rajendran. I have a question for you. What is the clinical reality, particularly in the Indian context, and how can clinicians begin by doing things better? Thank you so much.
Greetings from India. The slides are visible? Are the
Yes, we can
slides
see the
visible?
slide.
Fine. Fine. Over the next 10 minutes, I'll be taking you through how to narrow the implementation gap in CVD prevention and care. So what is this? Okay, just a minute. So what is this implementation gap and what it means actually? So we have some evidence and we have some real world practice, and there seems to be a huge gap across the countries. And what is this evidence? The evidence. What is this evidence? I've just taken a recent scientific statement from American Heart Association. That's a 2026 dietary guidance. It basically says evidence-based nutrition is all about prescribing a whole food plant-based diet without actually mentioning it. And the interesting point which I learned from this is that this has to start from the first year of life. So some more data on evidence. So evidence from the GBD, I have just taken the Indian stats from here and I have chosen to see what are the dietary cardiovascular risks. And if we see actually what are the dietary cardiovascular risks, it's the low fat, low fruit, low nuts and seeds, low whole grains, which predominate rather than a high consumption of red meat or high processed meat. When we look at the diabetes stats in India, again, it's a low fruits, which is more important rather than even a high sweetened beverages. So this is the most clinching evidence, and there is a myth. I'm sure it will be there across the world on consumption of low fruit, or consumption of fruits in diabetes. When we take the United States of America, look at that. The diabetes is most often, the nutritional factors leading on to diabetes is most often high processed meat, high sweetened beverages, and high red meat. So when it comes to India, low consumption of certain things. When it comes to USA, it is high consumption of certain things. So nutrition cannot be like, it cannot be one blanket prescription across the countries. So I've taken 4 states from India, Tamil Nadu, Kerala, and Punjab and Maharashtra. In all the 4 states, it is the low fruit consumption which causes the cardiovascular disease. I have also taken the same 4 states here and I have looked at the diabetes incidents related to food. It's again low fruit consumption and sugar sweetened beverages come only next to it. It is not even half of the cost cost by the low fruits. Basically between the evidence and the real world practice, and let's see what is the evidence, where does the evidence come from. I've just taken few latest references, one from the HA which says whole food plant-based diet, actually without mentioning the name. And I've chosen few other stats also from the global burden of diseases. This is available for everyone to see. I have chosen heart disease in India and I've looked at the dietary risk factors for CVD in India. So when you see that, this is a bit of a surprise for many of us. Low fruit, low nuts and seeds, consumption of certain things which we are supposed to, low consumption of certain things which we are supposed to consume in a high level is the most important cause. The same diabetes also, but the most surprise is the diabetes is most often caused by low fruit consumption in India, followed by low whole grains and high sweetened beverages. When it comes to USA, what is interesting is just exactly the opposite of what we saw in Indian context. High processed meat, high sweetened beverages, and high red meat is the cause for diabetes in USA. So again, I've taken 4 states from India. This is again with regard to CVD. The most important dietary cause is low fruit consumption in all the 4 states. When it comes to diabetes in the same 4 states, again, it's low fruit consumption. So I just went into the NIN, National Institute of Nutrition, that's an Indian guidelines, and just looked at the macronutrient consumption. We seem to be consuming more than what is recommended, definitely in terms of carbohydrate, protein, fat, and fiber. Only thing is the source of carbohydrate, protein, and fiber seems to be coming from cereals rather than pulses, nuts, fruits, and vegetables. The same thing applies to the fat. Fat more often comes from cooking oils and fat, or rather than from the nuts and seeds. So when it comes to India, the most important thing is we are consuming very less coarse grains and very less green leafy vegetables, which is the source of nitric oxide. And again, I'm touching upon the same thing again and again. Fruits and vegetable consumption is just 1.6% of the people are compliant with the guidelines in India. So is it something new actually? No. From 1977 onwards, the guidelines have always been mentioning that 400 to 600 grams of fruits and vegetables are to be consumed every day. 40 years of good service, but actually it's very, very poorly followed. And what will happen if we just continue to do this till 2044? We are going to have more than 2.5 million deaths because of this alone. And when it comes to India, it's again roughly around 1 million deaths are going to happen if we just continue not consuming fruits and vegetables in the right proportion. So we will come to the gaps in education. So in most of the conferences, when we attend the whole food plant-based diet, we focus on the nutrition controversies, whether protein has to be from animal, is that enough to have a plant protein, and what if we don't take fat, we will get a lot of other diseases, etc., etc. But we totally forget to talk about vegetables and fruits that I believe will make a huge difference across the world. So where do the gaps begin? The gaps begin with the physician. The physician is the center point. He is the only person who is capable of changing the healthcare systems, addressing the patient challenges, and he has to give the evidence to the government to change. National policies have to be changed based on the evidence given by us. So we many times gasp to fill the gaps. This is a reality. I'm sure this will be the case across because everybody is a human being. Despite advances, this is what we are facing. Pearl is our initiative. Pearl basically stands for Prevention and Early Detection. This journey started in 2019. The preventive cardiology department was started somewhere in 2015. But after 4 years, we started practicing this whole food plant-based diet. That was the COVID time and we had very less work. So we started educating ourselves. That is a physician team. And then we started educating the dietary team. And what was interesting is the whole food plant-based diet was prepared in our own kitchen for the first time in 2019, and people were surprised that a tasty food can be prepared without oil. In 2019, at the same time, we started experimenting on our patients who are highly symptomatic despite maximum pills and procedures. Repeat, they continue to be symptomatic. So we assess their symptomatic improvement and endothelial function improvement with whole food plant-based diet. When we had a great success. And subsequent to that, we started extending this to all our patients in the cardiology ward. So for the last 7 years, we have been providing whole food plant-based diet. And seeing that success, we started extending this to the diabetic patients. And we started showing the results to the endocrinologists. And that has led right now to a diabetic remission research. Slowly, we started encroaching the doctor's canteen to get more support from them because only when we get the physicians into our fold, we can expand our contribution to the society. So our doctor's canteen has right now become plant-powered, whereas the the canteen outside for the patient relatives has a small portion devoted to plant-based dining. We have not progressed to this level. As a developing country, we have our own problems with electronic medical records, but we have started using the systems effectively, setting up small goals. And I will show you some examples. And the one thing which is absolutely missing in our part of the country is AI-based monitoring and assessment. So what actually happens when the patient comes to our outpatient department? So when the patient comes to the outpatient department, either me or one of my juniors will be evaluating the patients, and we have a documentation in the EMR. I'll be showing them shortly. It's not a very well developed EMR or something, but we are still trying to make use of it for the benefit of the patients in terms of lifestyle modification. So we enter the ICD codes and make a nutrition diagnosis. Initially, it was pretty difficult to follow. And then the duty doctor sends the patients for all the investigations along with counseling sessions. They have while waiting for the investigation reports, on the same day the patient completes these 4 counselings, meeting a dietitian, physiotherapist, psychologist, and an yoga specialist. Once the reports come, the patient meets the staff nurse. The staff nurse sets the sets the targets, what all to be achieved in the subsequent years to the patient. And with all these things, the patient comes back to me. So I have all the reports. I will be updating the EMR on the metabolic parameters, vitamin B12 and D deficiency, because the patient is going to be on a whole food plant-based diet, only for those affordable people. And the patient goes home with a prescription of medications as well as the 6 pillars of health, an emphasis on that in a regional language. And the day is not yet over. After getting the prescription from me, the patient walks into the next room where the social worker literally reads out the entire prescription, tells why these things have happened the whole day, and gives him an appointment date. When the patient comes back for the second review, the patient has to come with the person in charge of kitchen at home, maybe the mother or the spouse, or even a maid can be brought, and he meets the dietitian. So this is how the cycle ends for the patient in terms of dietary counseling. Okay, so now we have slowly evolved at that. We have started giving them. Earlier, we used to give the complete whole food plant-based diet and tell them that you have to follow all these things, but it never worked for us. So we have started using this 1 veg, 1 fruit, and then adding on nuts and seeds. So for people who are interested, we have started sharing this. And the second thing is focusing on the quantity and quality of fruits and vegetables. The entire stuff is only focused on fruits and vegetables and not on the rest of the things. This is to basically improve the half the plate. We are focusing on half the plate concept entirely these days, unless the patient is for a secondary prevention. Okay, this is a model consultation note, a 30-year-old male coming to us for a cardiac opinion following the death of his father. So we have a reasonable recording of the patient's dietary habits and all the 6 pillars of lifestyle modification here. And the diagnosis part, now we are familiarizing ourselves with what exists as ICD-10 code. In that, we are very happy to enter the lifestyle diseases part, inappropriate eating, dietary habits, etc., etc. And the request is for the preventive cardiology counseling here. And this is what I said. The consultation note, along with the medication prescription, also has the 6 pillars mentioned over here, either in our regional language or in English, depending on this thing. So this is a new development from our side. The medical social worker sitting outside my room gives this printout to the patient, and he's supposed to fill up this every week and every month on his weight, base circumference, because unless they follow it up every week, they're not going to succeed. So this we have extended to our fruits and vegetable consumption as well as oil consumption. And of course, there are some other forms also, that is for the blood pressure and sugar monitoring at home. Sometimes we share this also for primary prevention. Actually, have we really succeeded? I would say yes as well as no. Yes is only in people who show willingness to change. Why is this happening and what should we actually be doing? Okay, can we actually create more time? I don't think it's going to be possible right now with the present workload. But I think the time can be effectively managed if we have a focused approach, whether the patient is a diabetic, whether the patient is for a primary prevention or a secondary prevention. A secondary prevention we may have to spend more time. For a primary prevention. Okay, we can phase it out. If we spend more time with the primary prevention, nothing is going to be followed. So it's always better to phase it out in small bits and pieces. And then if the patient's family is supportive and patient is also educated, then we can spend more time with that. This is about for saving time. And we should have by this time come out with a resource book, which is in process actually. And team expansion, again, I feel team expansion may not be possible, but we are actually finding some solutions, because people who are dining in our doctor's canteen, they have shown interest to join us and start counseling. This is a very easy way to do for us right now. And sometime down the line, I think a teaching kitchen and a culinary medicine course in our own institution will take us forwards. Okay, so PAN has been doing an excellent job. I've just put up three R's here. The most important R's are the regular CMAs. Of course, there are various forms of discussion, journals, etc., etc. But these are the three R's: research and readouts. We have already started doing. But I personally feel instead of CMEs, we should start focusing more on workshops. Right now, we are restricting it to physicians. Unless we include a nutritionist in the workshop, things may not work well. And we have to come out with our own documentation practices in India. And again, the toolkits, all the toolkits are, of course, to be modified to the Indian setting. The specific diet charts must be region specific. As I showed, our own cards, they need a lot of modification straight away. We find it difficult. And PAN has the ability definitely to come out with the National Nutrition Registry. I think it's time we start a fellowship program and some training on behavioral change. Basically on motivational interviewing for the doctors will help a long way to promote evidence-based nutrition with their patients. Well, I think PAN can start working on digital integration across the country. Region-specific nutrition guidelines slowly can start coming out. Research, yeah, I think we have started doing that, but I think the research must be definitely focused on region-specific work. It cannot be generalized because the cultural practices across India vary so much. And I think it's time we focus more on implementation science. I think we have lots of evidence for what we are already doing, but the implementation is the most difficult, and this seminar is all about that. This webinar is all about that. And the social media, I think, is effectively being used for giving information and countering misinformation. I think we should start giving more information like what I showed here based on the global burden of diseases to individual states that we should give more information rather than countering misinformation. And finally, at the end of every year, we should possibly have an annual review of programs and see what best we can do to improve ourselves. So is it all possible? I'm very sure most of you would have heard this Kerala story. They didn't actually change the people, they changed the system. They didn't prescribe vegetables and fruits. They actually preloaded the system. Everywhere it was made available. That is the only way out. I don't think it's straight away in our hands, but this is the way out, and this is what we should suggest to our national guidelines. And the carry home message is very, very simple. It's a team approach. So time is the most important constraint. Team building and focused approach will save our time. Education of the physician, which I think is already being done. Patient pamphlets, educating the patient's family, involving the patient's family is going to be the most important thing. And of course, the last one is the most important, public education. Access to whatever we say, depending on the socioeconomic status, we must be able to give an affordable one in small steps as far as it is primary prevention. And the last thing is the monitoring. That is where we are lagging behind. Now, India is showing some improvement in developing modern gadgets and multidisciplinary care. My message is form a team and follow this team message. Thank you. Thanks for your time and patient listening.
Thank you so much for your presentation, Dr. Rajendran. It's really inspiring, I think, for us to see a nutrition program integrated into healthcare, especially on a specialist level and not just in primary healthcare. So, and also to see health systems that are actively investing and promoting prevention strategies. This is really important for us. So I'm going to now hand over to our next speaker, who is Professor Ray. And my question for you is, what does the evidence tell us, and what does the health system need to do with that knowledge? Over to you.
Thank you very much, Nanine and Pan, for inviting me. And thank you, Dr. Rajendran, for nicely setting the stage with a wonderful regional case study. So I'm Shimon Ray. I'm going to be talking about cardiometabolic risk factors as they all feed into cardiovascular disease and where diet sits. But at the outset, I'd like to acknowledge some of my key team members, particularly Sarah Arms, who is mentioned on the slide here. So just a few declarations of interest. I'm speaking today in my capacity as the Chief Scientist for the NEDPRO Global Institute, but also as an advisory board member for PAN International. And in all of my roles, in one way, shape, or form, I do encounter the interface between nutrition and cardiovascular disease prevention or indeed intervention. A little word about who we are and what we do. The NEDPRO Global Institute for Food, Nutrition and Health has been running for 18 years, works across over 80 countries through 10 regional networks, and our main mission is really to advance and implement food and nutrition related knowledge in an applied context. And to do so, we're also responsible for a number of subsidiaries, notably our official journal, BMJ Nutrition, Prevention and Health, which also has a special collection on nutrition and cardiovascular disease, and our International Academy, which has a special interest group dedicated to the same topic. What we like to do is really develop evidence-based interventions and to then use that evidence to feed into education and training, often education and training that impacts clinical and public health practice, and ultimately influence policy and guidelines. So against that backdrop, I'm going to try and cover 4 different pillars today. So we'll take a little bit of a deep dive into cardiovascular research and what human interventions and data science look like, as I'm not only a practitioner, but also primarily a researcher, how we then synthesize evidence into pathways or causal inference pathways that link diet, nutrition, and cardiovascular risk, and indeed how all of the above feed into preventative nutrition practice in the form of guidelines and practical strategies, perhaps taking the cue from the previous talk, and then finally talking about a couple of emerging practice patterns in the broader arena of nutrition and cardiometabolic risk. So just to kind of start off with, I think it's really important to recognize that nutritional factors contribute to a number of different components of cardiovascular disease progression. And you can see on this schema that really those contributions are multifold, but endothelial function or dysfunction is really an integrated risk pathway that a lot of dietary exposures and also nutrients feed into. And really, the core aim is to prevent endothelial dysfunction and promote endothelial function for vascular health. So how do we do this in terms of research? So I've spent a lot of my life in the past 25 years that I've been in this field, measuring the impact in quite a nuanced way of different dietary and nutrient exposures on different aspects of the vascular system, and using different types of measurements that I won't go into detail on, but really looking at large blood vessels, small blood vessels, and using a number of modalities, which you can see on this slide here, some of the techniques that would be used in a nutrition related vascular assessment lab. This is flow-mediated dilatation, laser Doppler iontophoresis. The two look at large and small blood vessels complementarily in terms of endothelial function, then looking at the carotid arteries and the first signs of development of plaque, also looking at arterial stiffness using pulse wave analysis, and all of this complemented by the usual sort of vascular measurements. So this sort of toolkit over the past quarter century or so has given us quite a detailed typology of what nutrition can and cannot do in terms of mitigating cardiovascular risk factors. So I'm just going to say a few words about human nutrition interventions. We heard about the potential that plant-powered or plant-forward diets may have, and so we've dedicated quite a lot of effort over the past 2.5 decades to looking at dietary bioactive compounds. And these compounds are found in abundance in plant-based foods, polyphenols in particular. And these are just a few examples of randomized controlled trials that we have done over the years. We've done many more. And these trials have all consistently demonstrated that above a certain cut point, consistent intake of dietary bioactives, particularly polyphenolic compounds, in the presence of the right gut microbiota or microbiome, will then really transform those polyphenols into secondary metabolites that have their effects on different tissues and particularly endothelial function. The way in which that works is a little bit indirect. So we see a lot of marketing and messaging about antioxidant theory that is really debunked. But the oxidative stress in the body is relieved, particularly through a more subtle mechanism where nitric oxide sensitivity is improved in endothelial cells by these secondary metabolites of polyphenols. And these are really the components that are not on food labels, that are found again in abundance in plant-based foods, particularly things like soft fruit and pigmented vegetables. So that's just a little snippet of something that we found from our human intervention work over the past 2.5 decades. In terms of the data science that we've done also over a similar duration, we've been very fortunate to have full access to the 1946 British birth cohort. So I'm one of the cardiovascular principal investigators on this cohort. It's the world's longest running cohort of its type, where we have detailed waves of characterization of dietary patterns over the decades and about 80 years of data, including a range of different cardiovascular and metabolic outcomes. It's very interesting to look at how, when we look at the nutritional determinants, there is quite a lot of overlap in terms of cardiometabolic and cognitive outcomes, especially now that we're heading into the 9th decade. We also have the opportunity in my program of work to look at the National Diet and Nutrition Survey, which has 15 years of rolling program data on dietary exposures and also biomarkers, including cardiovascular risk markers, in a representative sample of the British population. And of course, we have had the opportunity to look at a huge variety of real-world data from our National Health Service. So again, what all of these pieces of data science tell us is that dietary patterns are important. Nobody eats the same food every single day, but if your dietary pattern conforms to the evidence around different components and the cut points of exposures of those components, which can, as I say, improve endothelial and vascular function, that is really the way forward. And how do we synthesize all of this evidence into causal inference pathways that could possibly link diet, nutrition, and cardiovascular risk? So this is a text that we have co-written with the British Nutrition Foundation, which is actually a compendium that has been updated on a sort of 10-yearly basis. And in the last update, there has been a very detailed characterization of the evidence, really looking at emerging risk factors. And those emerging risk factors are not only, but predominantly diet related. We also supplement this type of evidence synthesis, particularly looking at umbrella reviews. So really bringing together systematic scoping and narrative reviews in a way that we can draw out the pathways. And that is exactly what we have done to draw these pathways for conventional risk factors. This schema probably has writing that's a little bit small on the screen, but what I'm trying to depict here is the complexity in terms of different outcomes, whether we look at blood pressure, diabetes, lipids, or obesity. You can see that there are various factors which are on the right and various factors which are on the left, and a causal inference, not one pathway, but set of pathways that map the two. And really those lines which are darker purple, those are the lines where there is greater strength of evidence. But the interesting thing here is that sometimes what we find in messaging and even in common practice and guidelines isn't necessarily based on the strength of evidence, but is based on the strength of confirmation bias, because there are some areas that have been published more on and some areas that are talked more about. In terms of emerging risk factors, we've had the opportunity to look at coagulation, endothelial function, inflammation, and oxidative stress, which really form a cluster of intermediaries connecting diet on one hand and cardiovascular disease on the other. And finally, looking at nutrients versus dietary patterns, the one thing that I'd like to point out from this schema is that you see lots of purple lines connecting nutrients to cardiovascular outcomes on the left-hand side, and far fewer purple lines connecting dietary patterns. Now, this is slightly problematic, and it means that we need to, in the research, in order to really inform practice, move beyond single nutrient paradigms and single nutrient studies. Nobody eats single nutrients, so really creating heroes and demons amongst competing nutrients is not helpful. What we do need to look at is adherence and concordance to dietary patterns around which there is sufficient evidence of benefit, whichever those dietary patterns are. So we know that experimental studies support a causal role for hypertension, diabetes, and lipid factors, as well as obesity and cardiovascular risk. But we also need to think about several conditions and markers that are associated with conventional risk factors that could be better targets, and thinking about things that are underexplored, such as leptin or really fatty acids, are still unanswered areas in research. We also do know, as we said before, that there are these emerging risk factors centered around endothelial function. But really, there is a little bit of an imbalance between the amount of experimental versus observational evidence in this area, and that still needs to be strengthened. But what I'd like to emphasize is really emerging dietary risk factors, thinking about both nutrients and dietary patterns. So total carbohydrate and fat intake are not in the evidence base necessarily consistently linked to cardiovascular risk. But again, one of the things that we can say for sure is that sugar-sweetened beverages, low fiber intake, and trans fats are associated very strongly and consistently. And saturated fat and MUFAs are, of course, linked to cardiovascular risk. We don't necessarily always have the studies that will draw that out to mortality. But again, we have the studies that tell us about the mitigating factors, so sodium, potassium, and flavonoids. We also have a huge plethora of research on dietary patterns. The Mediterranean diet is one of the most studied dietary patterns, but it does not mean that everybody must follow just the Mediterranean diet. It means that we need to disaggregate the components and composition of the Mediterranean diet. And we have demonstrated in other studies that we've done ourselves that about a 2/3 adherence to those components of either the Mediterranean diet or the DASH diet, dietary approaches to stopping hypertension, even in a different sociocultural context with allowance for different types of foods, does achieve similar effects in terms of cardiovascular risk reduction. So that's what the research says. What can we do in practice? As I am also a practitioner and I run a dedicated preventative medicine service that focuses on nutrition and cardiometabolic disease. So here are a few kind of guidelines pulled together in terms of key preventative strategies. We've already heard about AHA. Here are a few more from Europe, from the UK, and also globally from the WHO. We know pretty much about the fiber story, fats, sodium, and minimizing processed foods, and of course the accompanying lifestyle measures that need to go with it. But what we don't know a lot about is how we ought to risk stratify properly in relation to diet. Other preventative strategies, of course, include managing chronic stress and the education of patients. But again, in order to stratify that education, we need to be a little bit more precise about exactly where nutrition sits on risk trajectories. So this is where dietary quality scores and cardiovascular risks come in. So diet quality scores can give us an overall kind of relationship between dietary patterns and health outcomes. And these can be used both in research and clinical settings. So common diet quality scores that we use are the Healthy Eating Index, the Alternative Healthy Eating Index, and so on. The one that I quite prefer is the Alternative Healthy Eating Index. It's very interoperable with different types of diets and has global application. And again, the key findings from research are that if we use a diet scoring system, if we use AHEI, for example, we can actually lower cardiovascular disease potentially by up to 30%. How do we use this? Of course, we need to use serial measurements in patients, but of course, use that to guide recommendations and modify our management by tracking progress. I think all of those people working in cardiovascular disease management will be familiar with some of the common risk scoring systems. Amongst these, I quite prefer the Reynolds risk score because it does take HbA1c into consideration. And when we've used the National Diet and Nutrition Survey and we have compared, for example, the Framingham risk score with the Reynolds risk score, there is much greater sensitivity using a score like Reynolds, which has HbA1c in it, to some of the baseline diets, which are determining cardiovascular risk factors in those segments of the population. So the pros and cons of different risk scoring systems are many. I'm happy to share a version of these slides with Pan if anybody wants to look at these. But you can see that every risk scoring system has some pros and cons, and it may be that you would need to use more than one depending on the context and the patient in front of you, particularly at an individual level. But at a population level, as I said, it's a good idea to use something that is sensitive to diet and compare that against traditional risk scores to see what sort of margin of error there might be. And those are really the people in the population that might be missed if we don't otherwise look. So some of the limitations of the traditional risk scores might be an overemphasis on lipids and blood pressure, and really an underestimation of lifestyle and diet. And these risk scores, let's remember, are hugely biased because they are developed predominantly in Western populations and in wealthy countries. So we do need risk scoring systems which are much more specific and sensitive to diverse populations. And also we don't have a lot of data in particularly the emerging elements of cardiovascular disease in younger people. So addressing the gap, I mean, there are lots of things that we can do in terms of innovation. Some of the basics are to integrate lifestyle variables, use modifiable lifestyle factors in all our care models, where risk assessment and risk management are two ends of the care pathway. But also we can do more novel things nowadays, use machine learning, particularly to interrogate routine health data to look at trends and opportunities, and also personalized risk prediction. And this is not just genetics, but also things like continuous monitoring and wearable tech. So primary prevention is really where a lot of our focus must lie, but we also need to think in secondary prevention about having a partnership between where medication may be necessary and where lifestyle measures are appropriate. But this does require that continuous doctor, dietitian, or doctor nutritionist partnership so that we can continually assess and reassess patients as they might be going into, for example, remission in the case of early type 2 diabetes, or indeed in cardiac rehabilitation. So a couple of words about emerging practice patterns for nutrition and cardiometabolic risk. So these are probably webinars in their own right, but I didn't want to leave without saying something about incretin-based therapies and also metabolic associated liver disease, steatotic liver disease, that is. So we see incretin-based therapies, particularly GLP-1 prescriptions, skyrocketing. These are statistics for the UK, but I'm sure these statistics look similar, if not far more exponential in some other countries. So we do need to think about not only using incretin-based therapies in terms of managing cardiometabolic risk factors, in this case, diabetes and weight, but also some of the longer-term nutritional effects and some of the side effects and unintended consequences which we need to mitigate. And this is a real reminder to those who may be using or may be thinking of using incretin-based therapies that really incretin-based therapies are only as good as the long-term projection of outcome, which is multifactorial. And so simply managing cardiometabolic risk factors and therefore creating other risk factors as a result without adequate attention to nutrition is a fallacy that we must avoid. And a word to say about MASLD really is that metabolic associated fatty liver disease or steatotic liver disease is really something that at least doubles the chance of cardiovascular events. And again, lifestyle interventions and dietary interventions can have a huge impact before we get into not only progressive liver disease, but also polypharmacy and multi-morbidity. So really what I'm saying is that we need to think laterally and not just look at the heart and the vascular system, but also think more broadly about the common denominator that diet and lifestyle can provide in terms of preventative health. And here you see a schema really where in the early stages, it is possible to mitigate the progression of fatty liver to steatosis, fibrosis, and so on. So what I'd like to say just to end is that we need to reach across primary, secondary, and tertiary care, and these sort of transition points between the three, and it really depends on how health systems are organized. Nanine talked about health systems. So what we need to do is think holistically and think about nutrition running as a thread throughout primary, secondary, and tertiary prevention, recognizing that there are different nutritional issues that are actually more predominant in one compartment versus the other. There are also different nutritional interventions that are appropriate for primary versus secondary versus tertiary prevention or intervention. So we need to not conflate those, and we need to first and foremost improve not only the literacy of our populations in terms of nutrition, but also the literacy of our practitioners in terms of what works and what doesn't, and what's appropriate at different levels of prevention. So that's a bit of a whistle stop, but I just want to part by saying that we had the privilege some years ago of writing the nutrition companion textbook to Kumar and Clark's clinical medicine. So if you're interested, please do have a look at that, and that covers secondary care. And we've also written all of the nutrition content in the lifestyle medicine textbook, which covers primary care. But really, this is another sort of ode to think laterally and really imagine that patients go on a journey, and we are there to support that journey through all of those elements of transfer of care. So thank you very much.
Thank you, Professor Ray. It was a very insightful presentation, and I really do hope that those who are in the audience today follow up with your resources that are very helpful for health professionals and doctors. So we don't have a lot of time left for questions, but we always love to take questions. So please do post some in the chat. I am going to get started with one question from Marjorie, who asks, I think I'm going to address this question to Dr. Rajendran. It is about digital support in your program. So we often talk about how practitioners don't have the time in consultations to really give nutrition counseling. So here is the question of, have you tried integrating digital approaches into your programs with patients?
Till now, no. We don't have that except basically for in WhatsApp groups, education and all. We don't have any digital platform with us. We tried once 6, 7 years ago with our own technology people, but then it failed. So now we are looking out for some grants now. We have applied for a few, and that's why I said that is in the process.
Well, it's good to hear that feedback. I think that technology adoption can be very different in different settings, especially among patients who might not have access to technology or even connectivity. So there's many barriers, although as well as opportunities to integrating digital products into our programs. Okay, so I think we could probably go with some more questions. So from both panelists' respective perspectives, we would like to know what needs to change in clinical practice, clinician training, and wider system support to really make nutrition easier to integrate into cardiovascular prevention and care. If you could think of that one unlock that you would suggest, and I would urge you to just think of that one top thing that you think needs to happen. And I will go to Professor Ray first, and then we can hear from Dr. Rajendran.
So I think medical and healthcare nutrition education is absolutely key. I think nutrition needs to be seen not as an added extra, but really as part of the integrated toolkit that all, not only doctors, but other types of clinicians have at their disposal. And it doesn't mean that every doctor has to become a nutritionist. It just means that people need to know enough to be able to screen and make a referral to a suitably qualified nutrition professional who can then contribute to the care pathway. And secondly, it does mean that we need to think about what those care pathways look like in different health systems, and defining those by principles is always helpful, because then in practice those principles can be applied in diverse ways.
I think I will say the same thing. Basically, the change has to come from the physician. And right now, the medical curriculum in India doesn't include too much of nutrition, except possibly for a few hours in the community medicine posting. So to make big changes, it's not going to be very easy. Even in the continuing medical education, it's more about drugs and certainly not about nutrition. So unless the physician changes, I think nothing is going to change. So, and the most important thing which I noticed in the last 5, 6 years is that even the dietitian, their syllabus also doesn't seem to include more about the whole food plant-based diet, very unfortunately. And it looked like a new term for our dietary team when we started discussing in 2019. So now they are convinced, because we have had two programs, one in patients with ischemic heart disease who are otherwise unfit for a procedure, and right now the ongoing program on diabetes. Now they are seeing the results, so they are convinced. And so the first thing, the change has to come from us. Unless we change, I don't think we can change the system.
That's a very valuable takeaway. And I think it also inspires us to continue on our mission at PAN, makes us really motivated to continue doing what we're doing and bridging that gap in physician education, but also promoting working in a multidisciplinary team and bringing physicians and together with dietitians for those important referral pathways. So I'd like to thank you both very much for such a thoughtful and insightful discussion today. I think that today's conversation has reminded us that nutrition is not just a side issue in cardiovascular health, but it is a meaningful part of prevention and management, and one that deserves far greater attention across clinical practice. So a sincere thank you to everybody who joined us today online. As we close, we would be very grateful if you could take a few moments to answer our post-event survey in the chat. Your feedback is extremely helpful to help us shape future events. So please go to the chat to find that link. We can also invite you to become a part of our Food for Health campaign as it continues over the year and over the coming months. We'll be releasing additional tools and resources soon. For those of you who want to stay connected in this amazing community that's here today and continue to engage on the topic, we encourage you to join us on Panco, our global community platform for health professionals. It is free, and there you can take part in the interactive side of today's event through polls and questions. I've already answered some of the polls and questions myself, so I really want to see from all of you what your perspectives are. So you can find the link for Panco in the chat as well. And on final note, just thank you again to our panelists, our speakers, and thank you all for being with us today. We hope you leave this session feeling encouraged, informed, and better equipped to carry this conversation forward in your work. Have a lovely day, everybody. Thank you.
Thank you very much. Thanks.
Thank you.